Okay, well, thank you all for coming and thanks for inviting me here. I'm a long way from Kansas. Um, my name is Kent Anselmi. I'm the National Sales Manager of Pulmodine. A little bit about myself. I've been a medic in the state of Kansas since 1980, and I still am. Started EMS in 1979, and I was marvel at the MRL out there because I used that and a Life Pack 4 long ago. So anyway, it's got nice, kind of brought back some great memories. But today we're going to talk a little bit about Cpap and the Cpap that I believe all of you have transitioned to, and that's the O2 Max Neb. So if there's any questions during any of this, please ask me, because it's a little bit different than what you were currently using with the Emergent. And I'll be real honest with you, the Emergent was a great Cpap. I mean, it really revolutionized respiratory care long ago. So, but things have happened there. So, everything you see in this bag that we talk about is made in the United States, and it's completely disposable. And we'll talk a lot about that in a little bit. The key to Cpap, and I'll say this many times during this, is Cpap needs to be started at bedside. Okay? The reason why is these people have been in distress for a long time. Some of you are frequent flyers, and we all have them. You know, they're sitting there thinking, oh my God, I can feel my lungs filling up. I'm having trouble breathing. I don't want to go to the hospital. I don't want to call EMS because I know what they're going to do to me. I know what happened last time. They can be 35, 40, 60 minutes into the episode before they call us. And if we wait, based on response times and everything else, till we get them in the back of the ambulance, you know, that's an additional 15, 20, 30 minutes, depending on where they are. So it truly needs to be started at bedside. And I think right now with the disposability of the O2 Max Neb, we certainly can do that. Like the Emergent, we use the high pressure side. And does anybody know why we use the high pressure side? Why every ventilator in the hospital, every anesthesia machine, Emergent, all the capital equipment, capital Cpap equipment uses the high pressure side. And we don't use the Christmas tree. It's okay. The reason why we use the high pressure side is that flow is unrestricted. That is nothing more than a check valve. And when I press that check valve in, I get constant flow out of the tank. Okay? I'll drain that tank within 5 minutes if I just hold that check valve in. Okay? Conversely, with the Christmas tree, like some disposable Cpaps are out there, it's restricted flow. And that's nothing more than a little pinhole that when I open it or close it, it just opens or closes, and it's very unreliable and very inaccurate. The other thing that's an issue with that is that flow is predicated on the pressure in the tank. Okay, so as my pressure in the tank drops, so does my flow. So it's a medic's nightmare. We continue to have to turn that flow up to maintain that adequate peak pressure, which those changes in that peak pressure affect the work of breathing. On the high pressure side, we can have 2,200 pounds in the tank or about 300 pounds in the tank, and we're going to get that same consistent flow. Okay, so that's why we use the high pressure side. And in a regulator in the back, in an ambulance, unscrewing the Christmas tree and screwing the circuit into that is not on the high pressure side. The high pressure side is the 50 psi 4. So that's why we use it. So there's 3 things in the bag, and I don't have a circuit with me or encapsulated. Well, yes, I do. I've got a circuit up here. But you can see, thank you, that it is very compact. Like I said, everything you need everything you need to deliver Cpap and nebulize a patient is in this bag. Okay, so it's easy to put on supervisors' cars, back of trucks, whatever. I'm going to talk about the 3 pieces that are in the bag, and it's very important. The first piece is the mask. The mask will come in a Ziploc bag. Nothing is sterile in this kit. We just put this mask in this bag just to protect it. This is a hospital grade mask, meaning literally it can go from the bedside of the patient all the way to the ICU, CCU. We sell hundreds of thousands of these masks worldwide in the acute care setting. The medium mask, which it looks like you're getting, will fit about 80% of the patients out there, and I'll talk about how you can size it. We also sell the mask individually, small, medium, large, and extra large. Most people across the country buy the medium circuit and then buy a couple large masks just to keep in the truck in case they have those people that they need it. Small is really small, and extra large is really extra large. The straps come attached, or the top straps come attached, as you see. What makes this mask so special is it doesn't take a lot of pressure to get a seal. And one of the problems that we see, or I see across the country, from people transitioning from the emergent to this mask, is with the emergent, you remember that yellow foam mask. It required a lot of pressure to get a seal. You really had to crank it on the patient's face to get a good seal. And the reason why, the attachment point was right at his nose. Okay, so you couldn't really get up high or low without really putting a lot of pressure on it. Conversely, with this mask, you don't need a lot of pressure. In fact, I call this a floating mask. I literally can put this on and I don't have hardly any pressure on this mask. And I have a really, really good seal. And the reason why that happens is there's two layers on this mask. The inward layer is for stability. The outward layer is for comfort. And actually, when the mask is pressurized, it blows against the patient's face, kind of like a skin diving mask. So men with facial hair, you will be able to get an adequate seal to deliver Cpap. It won't be a perfect seal, but you'll be able to get an adequate seal. One of the other advantages is if you're using end-tidal CO2, capno line, it will seal around that line and you'll be fine, okay? So where you want to size this mask, and this is very important, you want to size it at reading glass level, not at eyeglass level. And the reason why is if you get it up high and you have any blow by, you're going to blow that flow into the eyes of an agitated patient. You're going to agitate them even more, okay? So you want to keep it low. When we're delivering Cpap, all we really want to cover is the mouth and nose, okay? So, reading glass level, just like that, and everything's good. The head straps or the head pad adjust up or down, in or out for patient comfort. There's no set place where to put that. One of the other advantages to this mask is once I get it on the patient, the bottoms clip in. And if I want to give it nitro, all I have to do is unclip the bottom straps, and this swings up 90 degrees to give a nitro, and I can put it right back on without taking it off. I'm sorry, I'm talking through the mask. So that's another advantage to it. Everybody will ask what these ports are for. We're an international company, and in Europe, they'll take connecting tubing, and they'll connect it to this and increase the FiO2. Okay. I understand that you're all using the Trio, and we'll talk about that in a little bit. You'll never have to worry about that with that. So that's the mask. If you have a patient with a smaller head, there's an additional tab here that you can get a better fit on. Pretty simple. The generator, or the yellow box, if you will, is this. And if you all have any questions, please stop and ask me. It will come out of the box or the bag with a quick connect attached to it, which I'm sure you're all used to. No? Okay.
Christmas tree?
Yeah, I'll need a connector.
We're buying separate.
Did we do that because of price? Okay.
Okay. All right.
And we were able to get the capno lines in there. Capno lines, and so
Okay.
we're doing that separate as well as the trio separate.
Okay. So let me back up. I didn't realize you had the capno line in there.
Mm-hmm.
It's very important to get a baseline capnography before you put Cpap on, or it's good practice to do it. It's not mandatory, but it's good practice for several reasons. You can see the waveform prior to Cpap, And then obviously you can see an improvement in the waveform. You can see the waveform after you apply CPAP. And you can see if it's improved or if the patient's getting better. So it's real important to get a baseline using end-tidal. Now you're using the Capno line, right?
Yes.
Perfect. A lot of people think they can use the intubated line and there's too much dead space and everything else. One of the other advantages of using the capnography is it's a diagnostic tool. So what happens if I put that Capno line on? I've got a good waveform, not as great as we normally want, but I have a waveform. And I apply them, and I hook up the CPAP, and I put it on the patient's face, and all of a sudden I lose that waveform. What would that tell you? No, the patient's still breathing. The patient's still tachypnic, accessory muscle, diaphoretic. I lost my waveform. What happened? Did it get closed? No. Close.
Did is the mask too tight?
Mask is leaking. You have a leak in the mask, and you're getting all that air washing out that. So you can use it as a diagnostic tool for a good seal. Okay. So I'm glad you're using capnography, because this and capnography are game changers. Okay. So you don't have the ometer on it, but you're going to put it on there. Okay.
Show them how to take that out of the wall.
How to take it out of the wall? Just twist it.
You twist it.
Just like breaking a pencil. You can't pull it like this. Just twist it.
That is a normal issue among all
Very
departments. Mm-hmm.
You're not going to break it. Same thing with here. When you're into your flow meter or into your tank, just twist it.
I think they sent me one, and I used it, and then I got the wall, so I finally just, I don't know if it's right, but it worked.
Yeah.
All you do is twist it. All you do is twist it. And we can practice that here in a minute. So, if you don't have a pigtail on the tank, the redundant system is to take this off and screw it into the high pressure port. But we do. So, what I said earlier about that being a direct, source to the oxygen. Everybody says we're going to run through oxygen very, very quickly. Well, what happens when I plug that into the high pressure port? We gate that down, and we only pull 15 liters a minute from the tank. Okay? And we pull 125 liters from the ambient air, which gives us our flow of 140 liters at a fixed FiO2 of 30%. I cannot change that in this configuration. Okay? So on a full D tank, non-nebulizing, you get about 25 minutes. You nebulize, depending on what your protocols are, 6 to 8 liters per minute, you get about 20 minutes, depending on how long you nebulize. One of the other advantages of this system, this is a closed system. This is a 99.999 3/9 bacterial and viral filter. So if you've got bad bacteria or viruses out there, it's going to stop it from blowing down into the patient's lungs, which are already compromised. Okay, it's not going to stop everything, but it will stop the majority. It's got a higher bacterial and viral filtration rate than a HEPA filter. So it's a good system. One of the things, though, we want to remember is since we're in training 125 liters of air, we always want to keep this uncovered on top of a blanket, not towards the patient's chest like this, because it will stop that airflow or impede that airflow. So we want to keep it upright. No moving parts in here. No calibration. When you're done, you throw it away. It actually works like a jet engine, or it's a Bernoulli's principle is what it is. We have a large hole up here and a smaller hole down here. And that's what creates our flow of 140 liters. This will stretch to 6 feet or 72 inches. It does not have to be opened all the way for it to work. It doesn't have to be opened at all. One of the things that we hear every once in a while, it makes a whistle. Every once in a while you get a patient where it makes a whistle. So if you'll keep this collapsed about 3, 4, 5 inches here and pull from this side, it will stop that whistling. The reason why it's whistling is coming at 140 liters per minute. It's just turbulating through that corrugation, and that's what creates the whistle. It does not affect the efficacy of this system. Anti-asphyxia valve is right here. So if I lose pressure in my tank and I have the patient with a mask, they can breathe ambient air without suffocating. The PEEP is controlled here. You'll be getting the 3-set PEEP. It will come out of the bag at 5 centimeters of PEEP. Now I know with the immersion, we're used to turning it up into the green, yellow, green, whatever. With this, you hold the bottom, just like this, and if I want to go from 5 to 7.5, I just turn it, okay? And there's a little notch there, and you'll feel it. If I'm on that side of 7.5, I'll probably get 7.3. If I'm on this side, I might get 7.6. But you want to be kind of into that notch, and then we can take it all the way up to 10. Most of your patients, I'm a big believer in starting low and working up. The literature suggests that when people are in crisis, CHF, their PEEP pressure drops about 2.5. As we sit in this room right now, our PEEP is about 5. Okay, so if you have that patient at 2.5, 2.5, and you hit them with 10, that's like giving 10 milligrams of morphine if 5 is going to work. Start low and work your way up because it gives you a place to go. You're going to cure about 40 to 50% of the patients at 5 centimeters of PEEP, quite honestly, but it gives them that time to start getting acclimated to that pressure. And every time we increase the PEEP pressure, we increase the work of breathing. And I challenge you all is to put this on and start at 5 and work your way up to 10. Because when you get to 10, it's almost like breathing against that wall. It is really hard to breathe against. The service that I used to work for, we start at 10. There's a lot of doctors that feel that, just hit them with 10. That's fine. They're the doctors and I'm not. But so work your way up. So, will you hold this? To deliver CPAP, it's literally put the mask on, plug it in, that's it. Walk to the patient, coach the patient, you're going to feel a little air, they're going to feel it, and most patients, as you know, are going to grab this, because they're going to feel it, they don't need to. Now, one of the things that's important, watch this when I breathe. This is where the oxygen, this is the relief valve. So look it. Can you see it go up and down? There's another diagnostic tool. I'm watching the patient breathe. Okay, for whatever reason, if I lose that or don't see that, and the new ones will be orange so we can see it, you need to figure out what's going on. Okay, so that's how simple it is. Any questions about that, about the CPAP? It's really, 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 really simple.
And now, how are you going to dispose of it?
Everything you see in this bag is disposable, which is really important because when you got to the hospital before, you had to wait for the yellow box. You had to wait. So when you get to the hospital, if you have the Omida or whatever, and I don't know what the hospitals have there, some just plug it right into their oxygen tree, and you're gone. So it's really, and with this being disposable, or with this being a hospital grade mask, what's the first thing they do when we get to the hospital? Yeah, rip it off. Their V60, their BiPAP will fit into this machine, or into this mask. So if you can talk to the therapists in the hospital, or the nurses, or whatever, to continue that care, put them on the BiPAP right into this mask. Now, one of the questions will come up, well, it doesn't have an anti-asphyxia valve on it. Well, we're making an elbow that we can plug it right into their BiPAP machines. So, but this mask is a hospital grade, so you can continue that care instead of having to rip it off and reseat it. So, about 18, almost 24 months ago, I went to the company because one of the things that always bothered me is when we decided to nebulize, and we're nebulizing about 60% of the patients now, if not more, when we deliver CPAP. We always thought about nebulizing after we started CPAP therapy. So that meant we had to turn off the oxygen. We had to build this T-tube out. It was usually an open system. We had to bring in a different oxygen source sometimes. This one we don't. But all the while we're desatting the patient, okay? Because once you establish that PEEP pressure and you shut the oxygen off or shut that flow off, you're going to lose that PEEP, and you're never going to get back to where you initially were. It takes a long time to do that. So I went to the president and I said, I'd like to incorporate our T-tube or our port into the circuit. Drew it out and literally took it to the engineers, had it on the CAD drawing. We actually had it built the next day on our 3D printer, plastic printer. Our T-tube is different than any one out. Well, there's one other out there, but this has a check valve in it. This is still a closed system. This is nothing more than a dust cover. Okay. So when I insert the canister, the check valve goes up, it goes down. So one of the other things I insisted on is the kit has to have the canister and connecting tubing, because as a medic, I know if it's not in front of me, I'm not going to get it. Okay. It just makes it, if that capno line's not in that kit, chances are you're probably not going to put it on. It just happens. So this is in the kit. This will come in a plastic bag. If you don't nebulize, you can repurpose it. You can leave it in the hospital bin or some of your citizens, whatever. So to nebulize, all you really have to do is hook it to the same regulator. I am a big believer in taking your medicine and dropping it in the top. Nothing ever good happens at 3 o'clock in the morning when I unscrew this thing. Things just go everywhere. Okay? Just drop the medication in the top. Insert it, give it a quarter turn, it locks it in. Turn my regulator to 6 or 8, deliver whatever your protocols are, and I'll nebulize. Now, this nebulizer has a needleless port. So if I want to give a second treatment, I can take my albuterol pillow and I can stick it right through here and give a second treatment. That sounds real good in a hospital where they're not moving. But in the back of an ambulance, this is what's going to happen. All you have to do is kink the hose, pull this out, drop your medication in, put it back in. That's how simple it is. And now I'm nebulizing the patient. Nothing's changed. Any questions about that? I wish I could make this hard, but it's not real hard. Especially y'all that have been using Cpap for so you understand what's going on. Any questions before we move on to something else? Everybody comfortable with 30% FiO2?
That's kind of what I was going to use. That like the max that system's going to deliver is just 30%.
This system is, but I'm going to talk about another one that's going to help you do that. Why are you uncomfortable at 30% FiO2?
I wasn't uncomfortable.
No, I'm just asking a question because there was a couple heads shaking there. That's okay.
We had before, and then we went to one that was 95%, and it did a whole lot better.
The only clinical paper ever written on FiO2 in the pre-hospital setting was written by Dr. Bledsoe on the first generation of this, the O2 Rescue, where he clearly states that 28 to 30% FiO2 in the pre-hospital setting is adequate and fine. Oxygen is not what we once thought it was, and it's not really an oxygen problem. Cpap is not an oxygen problem, it's a flow problem. Okay, and I'm not disagreeing with you, but I'm just telling, it's all about the flow. Once we open up or splint those alveoli and where they can get good diffusion between the transpulmonary gap there, we'll do fine. There are, and of course, we don't want to give a lot of oxygen to COPDers. We don't want to give 85, 90% oxygen to COPDers. There are certain cases, however, that we need to give a higher FiO2. Okay, good. So they're not going to get them in the kit. They're going to get okay. So, and we recognize that. So if you have that patient that you feel based on capnography, based on pulse oximetry, based on presentation of the patient, might need a higher oxygen concentration. All you have to do is take the top of this off like this and put what we call on the trio. Now, I can go from 30% to 60% to 90% FiO2. So we have an answer to, now it's my understanding that these will be separate in the truck, because if you buy it like this, quite honestly, it's very expensive. The only, and you're not going to use them. Not going to use them that much, I wouldn't think. But you'll have the ability to increase that. Now, I will tell you, at 90% on a full D tank, you'll blow through it in about 8 minutes. In fact, the only, well, there's a couple certs, but the one that really sticks out in my mind, the Mayo Clinic buys it like this. And they called me, it's about 8 months ago. He said, hey, Kent, I got a question. We ran through 8 D tanks and 450 liters of oxygen on the ambulance in about 30 minutes. Is that normal? And I said, well, what did you have the FiO2 on? He said, 90. So it will blow through oxygen, okay? So just be cognizant of that. I stress this, use the trio in the back of the ambulance where you've got the M or the H tank, because by the time if you start at bedside, you can kind of figure out where they're going with that.
I agree with him on the COPD patients. I wouldn't even look at it. Just leave the 30 on the regular system, unless you see you're going to need it. But if you knock their drive out, you're going to end up intubating them back in the minute now.
And that's a really good point. As much as I'd like to say this cures everybody, we're gonna have to intubate patients. We're gonna have to, I don't know if y'all are RSI or what, we're gonna have to knock them down and intubate them on some patients. Obviously, this has reduced our intubation rates by 60-70%, but there are those patients that are just sick enough that wait too long that we're gonna have to do that.
Yeah.
But we do have, and I can get Emily that documentation from Bledsoe, but I think you'll be really surprised by using this at 30%. There might be a patient or two that you might go to 60. I don't know any patient that needs 90%. If they need 90%, they need to be intubated. Why not? Any questions about CPAP? Keys, the keys are high pressure. Gotta use a high pressure, which you're all used to. Okay. Sizing the mask, reading glass level instead of eyeglass level. Not a lot of pressure on the mask. If it leaks, loosen it. Okay, that's that's just crazy to think about. If you're getting leaks in that mask, loosen the mask. Okay. I'm going to put this mask on. I'm going to show you what I mean when I say it kind of pressurizes against my face. See how flowing against my face? Well, I don't have anything on this. It's blowing against my face. So that's really I stress that a lot because I've dealt with a lot of people that have gone from the emergent to this, and I usually get called, oh, it's leaking, the mask is leaking, loosen, which is really a good thing. Any questions? Like I said, everything you see with the exception of this, and we don't make this, is made in the United States, in Indianapolis, so we can react really quickly if you see something. One of the areas, quite honestly, and this is an older mask, is this is a kind of, I don't want to say an Achilles heel, but every once in a while we'll get a mask breakage right here. Remember, these are hospital grade masks. They're really made to sit in bins in the ICU, CCU. And in EMS, we like to put 10 pounds of you-know-what in a 5-pound bag. We like to cram bags. So if you cram a D cylinder on it or whatever, this may break. All you have to do is call Emily, and I'll take care of the mask. We'll fix it. But where I was going with this is we realized that was an issue. And the new ones coming out, which should be coming out of Boundtree very quickly, is we changed the plastic. We're a medical plastics company also. to what's called constrate instead of a polycarbonate plastic. And constrate is like our credit cards. When you bend them, it forms that white line, it won't break, where this isn't. So we recognize that, so you'll be seeing that coming out. So, but again, I'm not gonna say it's, you know, they won't break. I mean, you put a D-cylinder, we throw a bag or put a D-cylinder on it or something like that, it will. So, but all you have to do is call Emily and I'll take care of that bag or mask.